Okay, thank you very much to the organizers for the invitation, and I appreciate Dr. Krakowski's perspective. And I actually don't disagree with most of what he said. I'm just going to kind of offer a little bit of a different perspective. I will say that I agree that lasing moles, it has not solved the problem. And I am actually the one at the Women's Center investigating cryotherapy for moles.
There you go.
So if I thought we had solved the problem, I wouldn't be doing that. That being said, I think there are arguments to be made both ways, in that with appropriate decision-making and shared decision-making with family members, then a reasonable decision could be made to proceed. So I have no financial disclosures. This is a pediatric audience, so you probably already know all this, but I'll go through it, some general background briefly. I'm talking about congenital melanocytic nevi, not the acquired nevi, which were some of the nevi that you were talking about in your presentation. They can be small, so they can kind of look the same size as some acquired nevi, but they're about 1% of live births, generally categorized based on their size, and it's true that the risk of malignant transformation is higher in the large and giant ones, and in the small and medium ones it is not. It may be a little bit higher than baseline, but not significantly higher. The most common complication is neurocutaneous melanosis. So when people are getting melanomas, or not melanomas, but complications from their nevi, it's generally not in the skin, it's in the CNS. And when melanomas do appear in the skin, they are generally quite deep. So treatment options and consideration. So I will first state that observation is always an option. You don't have to do anything if clinically or just socially you don't think it's appropriate for the patient, or if the family doesn't feel it's appropriate. And I will also agree that if these are sufficiently disfiguring that you want to do something, that excision is a better option if it is an option. The problem is that in many of the most challenging ones, excision is not an option, even with expanders and the like. So then we're left with minimally, or quote-unquote minimally invasive treatments, such as laser. And so when would I not consider, and when would I consider a laser? Well, I would consider it if a patient is not a candidate for excision. And then there's, in a situation where there's obvious psychosocial burden of disease, where doing nothing is also a decision that has potential significant impact on the life of a growing child, and it's not simply a question of, well, is it cool to get rid of a mole or not? Dr. Krakowski went into the question about melanoma. I agree that the risk of causing a malignant transformation, or of increasing some sort of baseline risk of malignant transformation is not there. I'm not certain that removing part of a nevus, let's say a deep nevus, is going to greatly impact the risk of not finding a melanoma. Meaning, in the case that Dr. Krakowski referred to, of these very slow-growing acquired nevi that turned out to be melanomas, that's not the usual picture that you get with a large or giant congenital melanocytic nevus. There you usually get a deep nodule, and the physical exam is very much based on palpation and not as much on dermoscopy, although it's a point well taken. You also need to, so you do need the continued monitoring. I agree 100%. We're not curing or preventing melanoma by doing this. The only reason to do this would be to improve the life of a child. The family does have to be willing to tolerate multiple interventions, because as you noted, you do require many of them. Just a little bit about the history of this. There were early publications primarily with pigment targeting short pulse lasers showing effective but variable results. Long pulse lasers were introduced subsequently in an effort to target deeper structures, to target hair and melanocytic nests. So Professor Kono from Japan in the Annals of Plastic Surgery published in 2005 a series of 34 congenital nevi, treated it with a combination of short pulse and long pulse ruby laser. And they characterized the response to treatment by histologic subtypes. So these are the different histologic subtypes that they investigated. So here you have a junctional type, what they call superficial intradermal, deep intradermal, compound superficial, and compound deep. And skipping to the conclusion here, you have all these different histologic subtypes, and the physician-assessed lightening was pretty good in all of them after multiple treatments, anywhere between 70 to 87% on average. Of course, there's variable follow-up and the risk of repigmentation afterward, and that all goes without saying. In our own institution, where I have had the privilege to train under Dr. Rox Anderson and where I now treat in the OR and in the clinic many pediatric patients, we did a retrospective review of patients with congenital melanocytic nevi treated between 2010 and 2022, and we excluded those that were also underwent excision, and we had a total of 12 who underwent a series of treatments. So we're not doing a lot of these, but we are also not doing zero. The general characteristics, number one, was overall lighter complexion and only one with a darker complexion, with type 5 or above. We were also treating almost exclusively large and giant nevi. We were treating primarily on the face and scalp, areas where very public, very visible, and very impactful birthmarks. And most of our nevi were hairy, the majority of them. And just to go back here, so most of these that were treated by Professor Kono didn't have a significant hair component. They probably had some, but I think our cohort was biased more toward the deeper, hairier ones. In terms of the general results we saw, the median number of treatments for our patients was 5.5. We generally used a combination of treatments, a Q-switch and a long pulsed, and some ablative and non-ablative fractional resurfacing. And here are just a couple of examples. This is one subject who I'm currently, this is her to begin with. She had a darker portion in the middle, a little hairier, lighter on the outside. This is her after 4 treatments. She was pretty stable for a few months. She came back last month and she did have a little more repigmentation here in the center and hair, so we went back and treated it. So the point of repigmentation and the need for multiple treatments is granted. What I tell patients is that we're going to need to do a series of treatments at fairly frequent intervals, maybe every month or so, and then we can wait a while and see how quickly it repigments. If this is a type of mole that repigments really quickly and the only way to get the pigment out is to treat it every month for the rest of your life, well, we're not going to keep doing that. But if it repigments slowly, and maybe we do maintenance treatments once or twice a year, well, that's not all that different than the majority of port wine birthmarks that we treat. This is another patient. This is her at birth. This is her before she came to see us at MGH. She had undergone 11 Q-switched alone treatments, and then this is back when I was a fellow, and then subsequently as an attending, treated her with a combination of short pulsed and long pulsed lasers. This is her after 4 treatments, and then she started coming every 4 or 5 months or so, and this is her after 15 treatments, meaning she was repigmenting a little bit. She was coming every 4 or 5 months. We were keeping the pigment at bay. And then the family made the decision to not pursue treatment, as they were actually traveling from Arizona in order to do this treatment, so it was very inconvenient for them. And I've stayed in touch with them. They send me pictures periodically. She is repigmenting, and they're just making the decision as to whether to return to treat or not. But we did have a significant impact that lasted for a significant period of time on her nevus. And so quantitatively, we had 2 blinded physicians look at our cohort, again, which was biased toward a hairy nevi. The average improvement was 2.6, so somewhere between 50 and 75%, somewhere between fair and good, and 58% were good or excellent. Poor lightening was found. The ones who responded the least were those who had the fewest sessions, and there was no significant scarring or dyspigmentation or long-term adverse events. So key points. Again, excision is preferable if feasible. It should be considered laser treatment should be considered only if unresectable and if the appearance of the nevus presents difficulties for the healthy psychosocial development of the patient. It's very important to have shared decision making. Families that come and say, I want you to remove this nevus in 2 or 3 treatments and have it gone forever. Well, if that's the family's goal, then you're going to be honest with them and say, well, I don't have the technology to do that yet, so we shouldn't treat this. But if the family says, well, my child has half their face with a very dark, maybe even hairy nevus, and I want to do what I can to make it less noticeable to people who are going to see them close up or from a distance, well, then that's something that you may be able to help with. We have found a combination approach to be more effective than a single pulse duration approach. Eradication of the nevus is often incomplete. I will say usually incomplete. And as you noted, Dr. Kwiatkowski, that could be due to the penetration depth, superficial absorption by more superficial melanocytes of the laser light, so it's not getting deep enough. It can also be due to non-pigmented melanocytes, and the nevus can recur. So with these caveats, If you're willing to do maintenance treatments and you're willing to have an ongoing relationship with the family, and you're finding that your results are, over time, that your results actually are producing lightening of this lesion for an extended period of time, I think it is entirely reasonable to consider it. It's also entirely reasonable for a family to decide, no, it's not for them. So I don't disagree with much, it's just maybe a little bit of a nuanced approach. Okay, thanks.